I wanted to mention a few key tools and project models that we should be using more in our grant programs given their success. The first is a Nurturing Care Group core project model. This project model is a multi-sectoral version of the care group approach. The model is used to promote behaviors associated with most elements of the Nurturing Care Framework, which was released by the WHO and UNICEF in 2019, and that should make it more attractive to donors. The purpose of the model is to promote basic parenting skills and adoption of key behaviors from 4 out of our 5 World Vision sectors, including child protection. One of the reasons we're trying to use this model is that it allows us to work further back in the chain of causation of child deaths and malnutrition and to better address the neglected issues to improve child well-being. In particular, we need to reduce harsh punishment of children and child marriage, since a 10% reduction in child marriage can contribute to a 70% reduction in the maternal mortality ratio. With this model, there's the option to work with almost every household in the community, such as households with children 0 to 18 years of age, or a more targeted approach, such as households of pregnant women and children under 2. Working with the broader group allows us to promote behaviors that affect older age groups, such as adolescent nutrition, childhood injuries, menstrual hygiene, etc. We also have guidance on how to work with faith leaders using this model. With this model, field offices have the freedom to choose the behaviors to promote that fit within their given context. So we have about 70 lessons to choose from, and 15 of those are child protection lessons. Here are some of the features of this innovative Nurturing Care Group project model. One is it fits well with our World Vision's strategic initiatives. It's also multi-sectoral, it's plug and play and flexible. Since it's a behavior change platform, you can basically promote all sorts of different behaviors, as I mentioned. It's very low cost. It's only about $2 to $3 US per beneficiary per year. You can compare that to about $13 for the community-led total sanitation model, or $9 for the timed and targeted counseling model. Staffing requirements are low. You can staff it through current AP staff and people with hay grades of about 6 to 10 for the Nurturing Care Group promoters, or you can use local Minister of Health or Minister of Water staff, such as community health workers. It's highly cost effective as well. We've seen more than double the behavior change of many existing behavior change models, and the estimated cost per life saved is only about $441 to $2,204. You also get extensive beneficiary contact with it, about 20 to 26 contacts a year through both a combination of meetings and home visits, versus, for example, 9 for timed and targeted counseling. I won't go through a lot of this, but one reason that we should be including this model in our grants is that we have a tremendous amount of evidence for the care group approach upon which it's based. In this study, the important upshot is that we saw double the behavior change when care groups were used and 53% better reduction in child deaths with care groups. The link there to the evidence brief is at the bottom as well. And then this overall approach, what is actually is done in this project model that has led to some amazing results compared to traditional behavior change approaches might seem quite simple. You basically teach paid World Vision Nurturing Care Group promoters, community health workers, or other group facilitators to teach community volunteers how to promote behaviors from different sectors. And then you have those volunteers promote those behavior change lessons with the caregivers that they serve in groups of about 10 to 12. And you repeat that every 2 weeks. So that might sound like other models that you've used, but there are some key differences between this approach and other approaches that make all the difference. Things like the way you set up the groups, the coverage plan, how you select the volunteers, the meeting frequency, the lesson plan format, and the formative research that's often combined with it, and other elements. And remember, this is also a very inexpensive model. We have a 20-cent dollar handle for it. This model is also great when you want to show that you have something that produces sustainable results. This slide from a project using the care group approach in Mozambique shows that for this indicator, children receiving oral rehydration serum, rural relief saw an increase from about 47% to 82% during the project, which was a nice increase. But note how it increased further to 100% of care group caregivers that were sampled at 42 months after the project ended and all funding had ceased. They also found that 93% of those care group volunteers that were trained were still reaching women with behavior change promotion at 20 months after the end of the project. The results were sustained or improved upon at both 30 months and 42 months post-project on about 17 different indicators. This just shows one of those, but I've got the full set. They saw the same trend, either maintaining gains or during the funded project or seeing improvements after the end of the funded project on all 17 of those indicators. There's a second sustainability study on care groups that I'll also share with these slides. So we also have evidence now that this project model works for child protection. These are behavior change results in Ghana, where nurturing care groups were used to promote both WASH and child protection behaviors over about 15 months. And note that we had a control group in this project, which donors love to see, and we were able to show better behavior adoption in the caregivers reached with the nurturing care groups than those who were reached in that were in the control group by about 10 to 35 percentage points. After being reached with nurturing care groups, caregivers were less likely to use physical violence against child, more likely to often or always praise a child in 6 specific ways, more likely to know and practice relaxation techniques, more likely to inspect the home for safety issues, and more likely to do 8 different positive things with the child, like playing games with them, asking about their homework and plans for the next day, and inviting them to help plan family activities. We hope to publish these results in a peer-reviewed journal and can give you the link so that when we have it, you can put that into grants, but for now you can cite this evidence. We saw changes also in knowledge and belief, but I'll just include those results with the slide deck without going through them. We also another tool that we've used and that you could include in grant applications for any sector really is barrier analysis. World Vision has used this tool extensively in WASH projects, some in health and nutrition, and is beginning to use it in child protection. There are currently plans to use it in 3 countries, Kenya, Tanzania, and Bangladesh, to look at child marriage, and in Lebanon to explore child labor. We will probably be using this in the CP demonstration sites that Marilla will be talking about as well. Barrier analysis is a rapid assessment, formative research tool to identify the behavioral determinants associated with a particular behavior, such as child marriage, hand washing, or vaccine acceptance. We do these studies in order to develop more effective behavior change messages and activities, so it's an add-on to usually the current approach. Barrier analysis is based on the health belief model and the theory of reasoned action social and behavior change models. And a key feature is that you interview those doing a behavior, the doers, or intending to do the behavior, and compare the responses to those who are not, the non-doers. This then allows you to look for correlations between the responses and the behavior so that you can better identify what is driving behavioral adoption. Barrier analysis has been used in more than 1/3 of lower and middle income countries by about 30 INGOs, and it's being used by agencies like UNICEF. I developed this model back in 1990, so you can see in grant proposals that World Vision staff developed this methodology. Analysis is done with a simple spreadsheet, and barrier analysis was used extensively during the Ebola outbreak, and we're now using it to study vaccine acceptance with COVID-19. These are the main determinants that are explored in these studies, things like perceived social norms, whether you think that people important to you approve of the behavior, but also some factors like perceived severity, whether you think that something like COVID-19 or pregnancy complications are dangerous or not. These are the main steps in barrier analysis. It's quite easy to use. You create a barrier analysis questionnaire for this study from a template. Staff interview 45 or more doers and 45 or more non-doers over the phone or in person. You then count the number of doers and non-doers giving each response. You plug those numbers into an easy-to-use MS Excel barrier analysis tabulation table. And then staff and stakeholders use the findings on significant differences between the doers and non-doers to create useful messages and activities that leverage enablers and reduce the barriers. Even though a lot of organizations have used barrier analysis for other sectors, World Vision is the only organization that I know of that will be using this tool for child protection. So I think that gives us an edge. We have staff in the TSO that can train project staff to use the tool either through a 5-day workshop in the field or a more brief training over Zoom. And they can also provide text for proposals and input on the choice of behaviors to study. These studies can usually be conducted in less than a week with existing project staff, so they're not expensive and don't require research experts.